So beginning with the male reproductive system. The male reproductive system is a very, very simple anatomical system. There's not a lot to it, which is good. Not a lot to learn, not a lot to go wrong. So when we talk about the physiology, it's fairly simple. We talk about the pathology, it's fairly simple. And we include sexually transmitted infections under male reproductive system. Because when we discuss the female reproductive system, it's a lot more complicated and there's a lot more things that could potentially go wrong. So there's a lot of pathology that comes with that, as we could see. So I'm going to include some things, some pathology with that as well. So more so than I usually do in the past couple of chapters, probably mostly with the female reproductive system. I'm going to add a little more pathology to it when things go wrong. And of course, we'll talk about the menstrual cycle, which is really important to know about. It's always a little bit interesting to find out how many women don't really understand what happens during the menstrual cycle. Men, you guys get a pass. The fact that you don't understand it, that's fine. Maybe you'll understand a little bit more after today, but ladies, you definitely need to know what's going on. So, and then of course with childbirth, we'll go into that a little bit. So that takes us a little bit into growth and development, but I digress. So before we get started, does anyone have any questions? On this last day, sad day of anatomy and physiology lecture. Okie dokie. All right, we will get started then without additional ado.
Mr. Stanley.
Yes.
Good morning, Zay. Yeah, are you saying we're not gonna have A and P again?
You will not have A and P again.
So where are we gonna see you?
You will not.
Oh my goodness. I'm gonna miss you.
I know. It's very, very sad. Yes.
Yeah, it's so emotional for me. Like,
well,
well, I will have a long conversation with you on Thursday, right? When are we gonna take the exams? Thursday?
Yeah, a week from today.
So are we gonna be together with the other group or just as usual?
No, just you, just the Thursday group on Thursday.
Oh, okay.
9 o'clock at the school. Bring a pencil.
Okay, no problem then. I'll see you on Thursday. Bye.
Well, you'll see me today also, sort of.
Oh.
I mean, right? We're kind of seeing one another.
But we're gonna be seeing you at the school campus, right? When we started going to school.
Yes.
Like you're not gonna be with us, but we're gonna be able to see you.
Yes.
Oh, okay then. That's fine.
Yeah. Starting with the next group. I know I'm going to be back in teaching actually in person, which is going to be awesome.
Yeah.
So, good thing.
Well, at least you're gonna be around with some help whenever we need you.
That's true, because you will still run into anatomy, obviously. There's still going to be discussion of anatomy. You can't get around it. But
all right then.
Now, you know the basics. All right.
Mm-hmm.
We will get started with the male reproductive system. The male reproductive system is a pretty simple system. Males are pretty simple with their mechanics. Let's go to, they talk about classification of the organs, primary and secondary, or essential and accessory. The gonads of the male are the testes. And the accessory organs is everything else, as we will see here. Oops. Yeah, as we will see here. So, very simple diagram, which is nice, keeps things pretty easy. Starting with the scrotum. The scrotum is the sac of tissue that holds the testes and the beginnings of some of these tubes that are going to bring the spermatozoa, the sperm cells, and mix with the fluid that creates the semen. We'll see that the scrotum has muscles in its walls to allow for movement. The testis, this is singular. This is where the sperm are created, as well as testosterone. And then on the superior aspect and somewhat on the side of each testis is the epididymis. And we'll see that that is a connected group of tubes, and that then eventually winds back and forth. It's about 20 feet in length altogether. And these two together, the testis and the epididymis, is what is referred to as the testicle. So a lot of people sometimes misuse that term and call just the testis the testicle, but it's actually the combination of those two components. The testis plus the epididymis together is what we call the testicle. Testes is plural. That would be with an ES rather than an IS. Testis is singular. And the reality is, if people mix up that terminology, we don't get really upset about it. We know what they mean. You'll notice at the inferior aspect here, the epididymis makes a U-turn down here, and then becomes this long duct called the Vas Deferens. Let me get that into view here. The Vas Deferens, which actually goes back into the pelvic cavity behind the urinary bladder, and it merges with these two V-shaped glands called the Seminal Vesicles. You can kind of see that over here. There we are. So what is carried in this Vas deferens, this long tube, are the sperm with a little bit of fluid. The seminal vesicles add what's called seminal fluid, not surprisingly, which makes up somewhere around 70% of the volume of the semen. I think the book says it's more like 60%, but it's actually higher than that. About 70% of all of the fluid comes from this area, the seminal vesicle. The sperm themselves, very, very small. The sperm are the smallest cell in the human body. I think you can fit like 400 of them on the head of a pin. But they make up only about 2% of that ejaculate. So there's just a small part of that is actually made up of the sperm cells. You can see where the seminal vesicles attach to the ejaculatory duct. There's the ejaculatory duct right there in that walnut-shaped gland just beneath the male bladder called the prostate. So the ejaculatory duct comes in and connects with the urethra within the prostate. That area we call the prostatic urethra. And then the urethra is going to carry the semen all the way out the length of the penis to the outside world. Pretty simple. You can see those little pea-sized glands called the bulbourethral glands, also known as the Cowper's glands. They're going to add a little bit of fluid ahead of time because the urethra in the male serves dual purpose. Not only does it carry the urine from the bladder to the outside world, but it also is going to carry the semen with the sperm, and urine can be very acidic. So any residual droplets of urine that might still be in the urethra could be damaging to the sperm. So the bulbourethral glands are going to release a little bit of fluid ahead of the ejaculate to neutralize the inside of the urethra. That fluid is often referred to as pre-ejaculate, or I'm sure you have other names that you know of this, but that's the purpose. So the penis also, just like the urethra, has dual purpose. It carries the urethra to help expel urine, but is also part of the reproductive process. It is made up, we will see, of two groups of erectile tissue. There is a covering of the glans penis, which is what people would refer to as the head of the penis. The glans penis is covered by the prepuce, also known as the foreskin, which would actually cover the urethral meatus, the opening to the urethra. So it does sort of form, it does have a purpose. Having this removed via circumcision is an unnecessary procedure. There is no medical reason to remove the foreskin or the prepuce to perform a circumcision. In fact, most men on the planet are not circumcised, which actually makes researching this information very easy, because if people think that removing the foreskin helps with cleanliness, all you have to do is look at statistics in most every other country on the planet versus statistics in the United States, looking at things like infection, and we'll find that the rate is exactly the same. Or if you consider things like penile cancer, that was another concern, that a circumcision might decrease the rate of penile cancer. But again, if you look at the rates in most every other country on the planet versus the United States, what you'll find is the rates of penile cancer are the same. So it doesn't seem to make a difference. This is something that,
because those other countries aren't keeping track like we are here.
Oh no, they keep track. They do. Because these are other countries like England, France, Germany, Switzerland, Italy, Canada, Brazil. They're not, they're not places where there's a poor medical infrastructure. We're talking about places that are well built with an infrastructure. So most, all of Asia, well, most of Asia, countries like China, Japan, South Korea, India, areas in the Middle East, they keep really good records of things like, well, of everything in medicine. So yeah, it's really easy to compare. And that cleanliness issue isn't really a great reason to remove that. One could argue that we get a lot of dirt under our fingernails. So why don't we just remove our fingernails? That way we don't have to worry about dirt getting underneath them. Or we get a lot of dirt and fungus between our toes. Why don't we just cut off our toes? If we cut off our toes, then there's no between toes for things to accumulate. So it doesn't make sense to remove something like that simply because it gets dirty. We collect a lot of bacteria and organic material on our teeth. That's why we have to brush and floss. Could just make it easy. Just remove all of our teeth, take them all out. Then we don't have to worry about it. So it's not a good argument to say, well, for cleanliness issues, No, just clean it like you clean anything else. The smegma that collects, the smegma is a collection of like oil and bacteria and dead skin cells and things. That can collect in the female genitalia as well. But we don't suggest cutting away a lot of that tissue. So it just is not a good argument. It doesn't hold water. It's quite a barbaric process if you ever witnessed this. The baby is awake during the process because we're not going to put a baby under general anesthesia if we can help it. A local anesthetic is used through a ring block of lidocaine, but the baby's strapped down the whole time and is screaming the whole time. And then the terminology, if you listen to the terminology they use, is like clamping the tissue and cutting off the blood supply and crushing the tissue. It's pretty barbaric. Not to mention, consider the time frame when this is done, when this procedure is done. This is something that is done when a baby is really new. Remember, the growth period is 0 to 2, 4 to 7 in puberty. So they're doing a lot of growing during that time, that 0 to 2 time. So if you cut away tissue, what does the body want to do? The body wants to put it back. However, of course, they can only do that to a certain extent. The more tissue you cut away, the more difficult it is to put things back, but it still tries. This is why you will hear moms say that they had to take their child back to the hospital to redo the circumcision because they messed it up. No, they didn't mess it up. It's pretty idiot-proof, the procedure. What messed up was the child's body tried to regrow it. So it created scar tissue. So it had to be redone. Why put your child through that? It's terrible. Terrible, barbaric thing to do. And all we need is for one Kardashian to give birth to a baby boy and say, I'm not going to do a circumcision. And then the trend will catch on. People will do it just because the Kardashians did it, as is often the case. And hopefully we can abolish this. We know that it's better to keep all of your body parts. Remember, there was a time where the tonsils were taken out. The palatine tonsils were taken out routinely. Most everyone my age, by the time they were, 5, 6, 7 years old, had their tonsils taken out because it was just something that was routinely done. And all we knew at that time was we were going to get a lot of ice cream, but we didn't know anything else about it. And then there was a time where the appendix was routinely taken out, not because it had ruptured or was about to, but if a surgical procedure was being done in the abdomen and the surgeon noticed that the appendix was there, they would just take it out preemptively. They would take it out saying, just in case. Nothing wrong with it, but we don't want it to cause a problem. But we know these tissues do things. We know that they do have a purpose. So it's better to keep all of those parts, all that tissue. So that's my discussion on circumcision. Now, let's look at this discussion. The Vas Deferens, sometimes called the ductus deferens, as you can see here. The Vas Deferens is what carries sperm, the sperm cell, with a little bit of fluid, all the way back into the pelvic cavity. So there's not a direct connection from the testes to the urethra. There's the much longer route that this has to travel. And sperm can be stored for months at a time in the Vas Deferens. But if man decides he doesn't want to have children anymore and doesn't want to risk having an unwanted pregnancy, he can have a procedure done called a vasectomy, or as I call it, a vasectomy. ectomy to remind people that it's the Vas Deferens that gets cut. And it's a very simple procedure. This is done under local anesthetic. So again, a little bit of lidocaine injected here in the scrotum. And the surgeon will go in and separate out, isolate the Vas deferens from each testis, and then cut out a section of it and then ligate the ends. And then that's it. So it stops the sperm at this point from going any further. And then the body just reabsorbs them. So it's no big deal. But because the sperm only makes up about 2% of the ejaculate, there would be nothing else would be different. Everything else would be exactly the same. The only way you'd be able to tell if something was different is if you used a microscope and you looked for sperm swimming around. So it's a very simple procedure. It's a very easy procedure. I even found a video online on YouTube. It was on YouTube that a gentleman was having this procedure done, and he was filming it while it was occurring, which I thought was a really great idea, because for men who might be concerned about this process, about, thinking that it's going to change something and they're going to change the amount of testosterone, this is not a castration. They're not removing the testes. All they're doing is blocking the sperm from making it up back into the pelvic cavity to mix with the seminal fluid. And to be able to show that the discomfort was relatively low, especially once you get past the lidocaine part of it, that it's a very simple procedure. This is less expensive than a female having tubal ligation. This is easier to reverse than a female having a tubal ligation, with much better success, although I don't suggest that somebody get this if they're considering getting it reversed, because just don't get it to begin with. This comes with less complications. It's less invasive. It's not going into the abdominal pelvic cavity. So the recovery is fairly simple. There's a lot of positives to it as compared to a female having a tubal ligation. So something that men should know about as an option. Okay, so I think I'm done with that. The perineum. The perineum is the area between the anus and the scrotum, is the easiest way to describe it. And it's a good term to know, perineum, because it's going to be the same term in the female. So good term to know, perineum. It's roughly that area between the scrotum and the anus. So in the female, it would be the area between the vulva and the anus. The testes are about 2 inches in size. Let's just go right into the diagram here. You'll notice the testes have a whole bunch of compartments to them. And inside these compartments are what are called seminiferous tubules. Seminiferous tubules are the little tiny tubes where sperm are created. So here is a microscopic evaluation or microscopic view of these cut tubes. So if you took a slice of that area, what you're seeing are all these tubes, and in the center, the light area of those tubes, that's the lumen, that's the opening. And you can see here, from the outer edge of those tubes, there are lots and lots of these germ cells. Spermatogonia, the germ cells. And as we'll see here in a few minutes, the sperm cells, so pre-sperm cells, I guess we could call them, the germ cells, they are going to become sperm cells. In fact, each one will eventually become 4 separate sperm cells as they go through this process of division. And then those sperm, as you can see down here, are going to be moved into that lumen of the tubule. So the seminiferous tubules, let's see here, if we cut those, the view that we just saw is what could be imagined. So you can see now how many tubes there are here, and you can imagine how many sperm are being created. And then those tubes all come together in this roundabout called the rete testis, which then has these divisions that go into the epididymis, which link together into one long tube, which goes back and forth and back and forth and back and forth, which eventually comes down to this area where it makes the U-turn. At that point, it changes into the Vas Deferens. You'll also notice there's blood supply and nerve supply coming to this area, which kind of makes sense, I would think. Of course, it's living tissue. It's going to need nutrients. So notice how all this is bundled together, making its way down to the testis, even bundled together with the vas deferens, bringing the sperm back up into the pelvic cavity. And I point this out because we're going to see in a little bit, but that all of these vessels sort of get wrapped up together into one neat little package. Pretty smart. Keeps it really convenient. Keeps from having tubes just dangling all over the place. It works out well. So let me go back to this one. Seminiferous tubules. Remember, a tubule is just a small tube. Suspended in the scrotum by attachments to the scrotal wall and the spermatic cord. We're going to see the spermatic cord in a little more detail coming up. Leydig cells, you'll hear me refer to these as interstitial cells. These are the cells that produce testosterone, the most abundant and biologically active of the male hormones. You won't hear me use the term sustentacular. You'll hear me use the term Sertoli, but I'm not going to go into too much of what they do. Yeah, I think the only one I really want you to know about is the interstitial cells. Yeah, the interstitial cells are the cells that make testosterone. Those are the ones I want you to know about. Spermatogenesis. Production of the spermatozoa. Spermatozoa are the sperm cells. In the process of making those, spermatogenesis. Genesis means the beginning or the creation. So the creation of sperm cells, creation of spermatozoa. Testosterone causes the development and maintenance of the secondary male characteristics, sexual behavior. Stimulates protein anabolism, affects fluid and electrolyte balance. Yeah, I think that's all I have to say about that. Okay, I was going to go into something else, but I think that's enough. I don't need to go into anything more. So here we are back to the seminiferous tubules. We see these germ cells. Notice they have 46 chromosomes, just like all the cells in our body have 46 chromosomes. Remember, we get one of each pair of chromosomes from each parent. Pardon, so there are 23 pairs of chromosomes for a total number of 46. So we have one pair of chromosome 1, one pair of chromosome 2, one pair of chromosome 3, and that's all the way up to 22. Those are the autosomes. And then we have chromosome pair 23, which are the sex chromosomes. Males have an X and a Y chromosome, females have two X chromosomes. So each cell is going to have either an X chromosome or a Y chromosome in it. Just like each egg cell, each sperm cell. No, let me rephrase that. Each sperm cell will have either an X chromosome or a Y chromosome. Each egg cell, the ova, is going to have just an X chromosome, but they're still going to have one copy of the sex chromosomes. So how does that come to happen if we start out with 46 chromosomes total? Well, this germ cell is going to go through divisions. Not surprisingly, what we're going to start out seeing is a mitosis. It's going to make a copy of itself. We saw this same kind of thing happening with the hematopoietic pluripotential stem cells in the bone marrow. We saw that initially the first thing they do is copy themselves, and that kind of makes sense because otherwise you would run out. So these cells here are going to first go through a mitotic division and copy themselves. Then they're going to go through this meiotic division. Meiosis is where we have this break into copying into, instead of one new cell with 46 chromosomes, it's going to become two cells, each having 23 chromosomes total. Then those two cells are going to go through another meiotic division, where each of those cells is going to make a copy of themselves, so that we end up with 4 sperm cells altogether. During these processes here, there is a shuffling of the genetic material, meaning parts of chromosome 7 from one chromosome will mix with parts of chromosome 7 from another chromosome 7. Just like one would shuffle a deck of cards. This is where a lot of the genetic variability comes from. It happens as a result of the shuffling of all this genetic material in these areas here, in these meiotic divisions. Then eventually having these spermatozoa, notice the term spermatozoa, it just means a sperm cell, are now in the lumen of that seminiferous tubule, which are going to be moved to the rete testis, to the epididymis, to the vas deferens, back into the pelvic cavity to mix with the seminal fluid from the seminal vesicles. And remember, the sperm can stay inside of the vas deferens for months at a time. There can be a collection of sperm there for months. So even after a man has a vasectomy, he still has to be aware that pregnancy can still occur for a while. So he has to be careful if he doesn't want to have an unplanned pregnancy. Okay, the anterior pituitary gland controls the testes by means of its gonadotropin releasing hormone. Seems to me the gonadotropin releasing hormone does not come from the anterior pituitary gland. I don't know why that's in there. The anterior pituitary gland does not release gonadotropin releasing hormone. The hypothalamus releases gonadotropin releasing hormone. The anterior pituitary gland releases these two hormones, follicle stimulating hormone and luteinizing hormone. So I wonder if that's a typo. Somebody either meant to put hypothalamus or they meant to add anterior pituitary gland in a different location. But the anterior pituitary gland releases follicle stimulating hormone and luteinizing hormone. Follicle stimulating hormone in the male is going to stimulate the production of the sperm. Luteinizing hormone in the male is going to increase the production of testosterone in interstitial cells. looking at the structure of the sperm, the head of the sperm has a little cap on it, the acrosome. The nucleus, of course, is where the genetic material is going to be located. And notice the mitochondria and the centrioles are in connection there. They're going to be operating the machinery of the flagellum. And the flagellum is that long tail. Now, that tail does not go back and forth like a tadpole or a fish or something. I know that people seem to think that that's what happens, or a snake, but that's not what happens. That flagellum actually corkscrews. That is how it causes propulsion. It actually pulls the sperm forward. The same way a propeller on a boat pulls the boat through the water. If you look at a boat, obviously, you know the propeller is going to be located in the back portion of the boat. It is not pushing the boat through the water, it's actually pulling the boat through the water. So that long tail doesn't push the sperm through the fluid, it actually pulls it through. And the flagella are not unique to spermatozoa. They are found on other things as well, like bacteria, for instance. Bacteria often have several flagella that they use for movement. So it is not unique to sperm. This is something that is a useful tool in the animal kingdom for moving these small things around. And they are living cells. They utilize fructose rather than glucose. I know you've heard me say that most every cell in the body defaults to glucose as the major fuel source, and that's correct. That's the main default. That's what most cells use initially. But the sperm actually use fructose as their main fuel source. And I think that's all I have to say about that. Yeah. Okay, I talked about the epididymis. The epididymis has the ability to also store sperm. It also has the ability to sort. And it doesn't really include that in here. So if there are some defective sperm, they can be sorted out in the epididymis. There's an extra little cap that's added to the head of the sperm in the epididymis that helps to aid in the sperm penetrating the egg, although that cap doesn't get activated until later on with help from the prostate. The Vas Deferens, this tube, not surprisingly, has a muscular wall, because remember, we want to move stuff. The best way to move stuff is with muscle. So it helps to move that sperm all the way up through into the pelvic cavity. And it attaches, it says here it is written that it attaches to the ejaculatory duct. It actually attaches to the seminal vesicles, those V-shaped glands, and then those seminal vesicles attach to the ejaculatory duct. So there's a little bit of a miscommunication there. The ejaculatory duct attaches, okay, to the prostate. I'm sorry, to the prostatic urethra within the prostate, and here we can see that. There are some notable things here, lots and lots of notable things. So let's look at some of this. First of all, we get a better look at those V-shaped seminal vesicles that are on the posterior wall. They're on the back of the urinary bladder. And that's where the connection happens here, the ejaculatory duct with the urethra, and that is occurring within the prostate gland. That prostate gland is right at the base of the male bladder. Something I want you to see here is that all of the blood supply, plus the nerve supply, plus the vas deferens is all connected, no, all surrounded by something called the spermatic cord. So the best way to envision this, if you consider someone's office desk and their desk has a computer on top of it, like a PC with a monitor, with a keyboard, with maybe a printer attached next to it, and then maybe something else, the phone lines, all these cords running off of the back of the desk over to power supplies and things. You can imagine how that could be unsightly. They could get tangled up, people could trip over them. So you could put something around that would wrap up and sort of bundle all these cords together so it wouldn't look like just a big mess of cords. And if you did that, it would decrease the likelihood of people tripping and make it look much less unsightly and just sort of hold everything together better. That's what the spermatic cord does. The spermatic cord is bundling all of these tubes, the vas deferens, the blood supply, the nerve supply, all together. And then it sort of comes being continuous with the lining around the testis. And if you look at the blood supply, you can see the testicular artery in red, the general nerve in yellow, the vas deferens as well. But look at the veins that are taking the blood back up into the body. Notice how it's noted here as a venous plexus. The reason for this is because it acts to help control the temperature in this area. And that's an important thing because the sperm need a specific temperature in which to be able to go through this process that we saw, that production of the spermatozoa. So one of the things that can help regulate the temperature a bit is this venous plexus kind of acting like a radiator. As blood moves through it, it can dissipate some of that heat. It can collect some heat if needed. And you'll see part of the cremaster muscle here. They don't have the dartos muscle as well, but I thought they did have it. There's two main muscles that are included in the scrotum: the cremaster muscle and the dartos muscle. And the reason why there are muscles in the scrotum is because, well, there's going to be movement. That's what muscles do. So why would the scrotum need to move? Well, again, because of the reproductive needs, the requirements of the spermatozoa in order to go through that meiosis and mitosis processes, the temperature has to be just right. So if it is too cold, then the testes can move closer to the body, and that can add that additional heat that would allow for the sperm to be at a temperature that offers them the ability to go through mitosis, well, the germ cells to go through mitosis and meiosis. So if, of course, if the temperature is too warm, the muscles relax and the scrotum moves further away from the body. So that's why there's two, the dartos muscle and the cremaster muscle exist for that purpose. Something else I want you to notice here, the inguinal canal. The inguinal canal is an important opening from the pelvic cavity into the scrotum. And it's well designed. But what needs to be understood is that the testes develop in the pelvic cavity while that baby is still in the uterus. And then typically about a month before birth, those testes will move from the pelvic cavity through the inguinal canal, and they'll bring that spermatic cord with them, and they'll move down into the scrotum. They will descend into the scrotum. And then the inguinal canal will tighten up so that it doesn't allow for retraction. It doesn't allow for things like a loop of intestine to slip down through. Because if that happens, we call that an inguinal hernia. So if those testes do not move down into the scrotum within the first year, then the pediatricians will say we need to do surgery and descend these testes. I don't know if it's the American Association of Pediatricians or the American Association of Pediatric Surgeons, but the guideline is if they haven't descended in a year, then the child's going to require surgery to descend the testes. But nobody waits that long. Typically, if they haven't descended within 6 months, they start making plans at the 6-month mark to do surgery, just surgically descend the testes. But in either case, whether they descend late or if they're surgically descended, it's important that mom knows that the child is at an increased risk of developing testicular cancer. So she needs to know this so she can pass it on to her child so he knows to make sure he's aware to look for changes. Testicular cancer is a young man's cancer. Testicular cancer is something that occurs typically between the ages of 15 and 35, 15 to 37, something like that. The good news is it's usually unilateral. So only one testis is involved. And if it's caught early, very high success rate of just removing the testis, and that's pretty much it. And the other testis will still create plenty of testosterone, so they don't have to worry about that. They'll still create plenty of sperm, so they don't have to worry about that. Oh, I'm just getting a message now. Canvas is experiencing an issue. Yeah, no kidding. Thanks. They're an hour late. That's all right. I'm sorry about that. So I digress. That's the inguinal canal and the purpose of that. And it looks like there's one opening here, but there's actually another opening at this end.
Sir?
Yes.
Yeah. What age did you say again?
What age for testicular cancer?
Yeah.
The age range is typically 15 to 35 or 15 to 37.
Okay. Thank
So
you.
it's a young man's cancer. So high school age boys are taught to look for abnormalities. You know, we don't teach people to look for cancer. That's not when they do a self-testicular exam or a self-breast exam. They're not being taught to look for cancer. They're being taught to look for anything that is abnormal, anything that is changed or is different, and then to relay that information to a medical professional. So we used to teach young men to do a testicular self-exam like once a year, and we'd say choose a date like January 1st, the new year, or your birthday, and then just do it once a year. And then that was changed to twice a year. And now I think they're actually suggesting monthly, look for any changes. But again, it's just something that is different. If there's a change, tell somebody. That's it. And the success rate with treatment is really, really high. But, okay, where are we? All right, we're still good. Let me pause for a minute. So I'm going to pause. I'll be right back. Okay, well, we are back. We will pick up then with more of the anatomy of the male reproductive system. Specifically with the penis. And you should be able to see my screen right about now. Okay. There are, can I see them a little bit better in the cut section? There are these spongy tissues that fill with blood. There are two on the dorsal or top side of the penis called the corpora cavernosa. And there is one on the underside called the corpus spongiosum. And these spongy tissues fill with blood, and that is what causes the distension during erection. And there's, in order to fill with blood, the arterial side needs to increase blood flow to these tissues. So there's an increased amount of blood flowing into these tissues. But on the venous side, there is a constriction. So there's a decreased amount of blood leaving those tissues. And that, of course, is what creates that distension. And I think that's about it. There's no muscle here. This is not a muscle. There's no bone in the male penis. Although in other animals, in other mammals, there is a bacula, or baculum, singular, bacula plural, but not in the human male. So that is that. Talked about the V-shaped seminal vesicles on the posterior aspect of the bladder. And again, here it's saying about 60% of the volume of semen. I'd say it's more like 70%. So in other words, the majority of the fluid is from the seminal vesicles. The prostate is going to add 20 to 30% of that fluid. And the fluid coming from the prostate is going to do a couple of things. It is going to activate the little cap that is on the head of the sperm that is going to help make it penetrate the egg, the ovum. It is going to break up the semen so that it makes it easier for the sperm to move around. It is going to also act to destroy some of the bacteria that's in the vagina that can actually be damaging to the sperm. So it has several different purposes, this fluid that is created from the prostate. The bulbourethral glands, I talked about those a little bit already. These two little pea-sized glands. Here it talks about the dartos and cremaster muscles that can elevate the scrotum. So I already discussed those a bit. There is a wall actually in the scrotum as well. Oh, there it is. Okay, divided internally by a septum. Talked about already the erectile tissue in the penis. And of course, its job in both reproduction and the urinary system. Talked about the spermatic cords, how they wrap everything up. Oops. Seminal fluid is where you're going to find that fructose. So in the couple of milliliters of ejaculate, can be anywhere from 2 to 5 milliliters. we're going to find anywhere from 100 to 500 million sperm. Now that's a lot. 100 to 500 million is a lot of sperm. And there needs to be a lot, because by the time the sperm actually make it to the egg, the count goes from 100 to 500 million down to about 2 dozen. So that's a big drop in number. A lot of sperm get lost along the way. So if a male has a low sperm count, that is going to greatly decrease the chance of fertilization, greatly decrease the chance that those sperm are going to make it to the egg. And you see here, if the number goes,
what caused the sperm count to go so low?
there aren't many external factors. In other words, most of the time, it's not something that the man did or didn't do. There is some correlation between maintaining a warmer temperature in the scrotum with an overall lower production of sperm. So if a man constantly wears really tight undergarments as compared to looser undergarments, the tighter undergarments keep the scrotum closer to the body. Because of the temperature, the sperm aren't able to produce as well, so the number goes down somewhat then. But whether or not it decreases it enough to get it down to less than 25 million, that's difficult to know for sure. In other words, if a person would normally have 200 or 300 million sperm per ejaculate, and then now, because they wore tight underwear, now their sperm count goes down to only 30 or 40 million. Is that really the only cause? I don't know. But it's one thing that can add to that lowering of the sperm count. A lot of the times it's simply the result of the person's body just not making enough. So external factors are less likely in most cases. People say, well, what about sitting like in a jacuzzi, in a hot jacuzzi? Because that, again, really warm temperature, decreasing the potential for sperm to be produced. I would say they'd have to do that a lot. They would have to be sitting in jacuzzi every day for hours and hours and hours every day. But as soon as they got out of the jacuzzi, their body would go back into trying to go back to normal numbers again. Whereas, of course, wearing tighter underwear, people do for hours and hours and hours every single day. There's also, you may have heard rumors of things like certain beverages, certain soda beverages. I don't want to mention any names, but it's a yellowish beverage. I don't know how to describe it. Yeah, I don't know how to describe the beverage without saying anything that might get me in trouble. But that beverage is supposed to cause low sperm count. That just is not true. There's no truth in that. Because if there were, then all a person would have to do is wear tight underwear and drink a lot of that beverage. And then they could decrease their sperm count so as not to cause pregnancy. There would be no need to have to go and get a vasectomy done if it was so easy to just drink that beverage and wear tight underwear. But that's not the case. So there is no truth in that. Change in the amount of testosterone can cause it as well. So if a person intentionally altered the amount of testosterone, that could do it as well. Otherwise, not really. But I mean, if you look at the numbers, 25 million is still a lot. That's per milliliter. That's a lot. And then if a person has a sperm count below that, below 25 million sperm per milliliter, the diagnosis is going to be infertility as a result of low sperm count. However, what if some of those sperm happen to be really strong and make their way through? Well, then pregnancy occurs. And the guy's a little confused because he says, but the doctors told me I was sterile, I was infertile, I couldn't get somebody pregnant. Yeah, it certainly decreases the likelihood, but it's not impossible. That would make for an interesting episode of the Maury Povich Show, that's for sure. But I digress. Infertility can also be caused by production of antibodies some men make against their own sperm. Not terribly common, though. It's probably more common that the woman's going to create antibodies against the sperm. Male fertility begins at puberty and extends basically forever. What that means is at puberty, men start making sperm and they pretty much don't stop. So this chart here is showing a couple of things. It is showing testosterone levels. And because testosterone is responsible for the development of male sexual characteristics and secondary male sexual characteristics, it would make sense that we would see this in the fetal time and a little bit in the neonatal time, and then definitely going into puberty. And we can see how, look at the numbers down here, it goes from 1-year-old to 10-year-old to 17 to 40, 60, 80 years old. And look at how the testosterone levels still stay relatively high, even as that gentleman enters their 7th decade of life. And notice in the blue line is sperm production. So there's still plenty of sperm way up again into that 7th decade of life and then some. There's still lots of sperm being produced. Now, what's the purpose of that? Speaking from an evolutionary standpoint, what's the purpose of being able to produce sperm into one's 50s, 60s, 70s even? Because a person is much less likely to be able to care for a newborn when they are 75 years old, 80 years old, 85 years old. What's the purpose of that? Because a woman goes through menopause and she is unable to have children after postmenopause, during or postmenopause. So again, speaking from an evolutionary standpoint, it would make sense that her body would say, okay, it's time to stop considering production of children. But of course, women do have to have the burden of carrying the developing child and the process of childbirth, which physiologically changes so many things that it would stress the body greatly to try to give birth at an older age, whereas the male doesn't have to worry about that aspect of it. So again, what would be the purpose from an evolutionary standpoint, someone older like that, other than simply to pass on their genes? The interesting question. I don't know the answer to. And it's obvious that evolution has found a benefit to extending life being older. There's definitely a benefit to that, which is probably in the form of passing on knowledge. So if somebody were to ask me the question, as people have asked in the past, why is it men can still produce sperm at such a late age? I don't know the answer to that. And that's all I have to say about that. And in fact, that's the end of the slide. So I'm going to go into something a little bit different now. A couple of things. Let me go back a few pictures here. No, yes, actually. I talked about the testis coming through the inguinal canal and bringing the spermatic cord along with it. If that doesn't occur, this is called cryptorchiasm. And that is when one or both testes fails to descend. The procedure is called an orchiopexy, to surgically descend that. Something else I'd want people to know with regard to the scrotum and the testes. Inflammation of the testes is called orchitis. O-R-C-H, itis, orchitis. Now back, I don't know, week 1, week 2, week 3, week 4, I talked about inflammation, and I said there's 2 main things that cause inflammation: injury and infection. And of course, under injury, I always include allergic reaction. So if a patient has orchitis, inflammation of the testes, it can be caused by things like trauma. That can cause injury, or that can cause inflammation, injury, therefore inflammation. Or if they have orchitis, it can be caused by infection. And infection, of course, can be bacterial infection or viral infection, most prevalently. However, the one I want you to remember is virus infection, specifically the Mumps virus. The Mumps virus can cause orchitis, inflammation of the testes. And that's an important one to know, because remember, the mumps, this is a virus that we do have a vaccine for, but it is reportable. As with most diseases that we have a vaccine for, it's a reportable disease. In other words, we want to keep track of it. Mumps virus is something that we hadn't seen in the United States in a long time, or few cases. You didn't see very many. But there has been an increase in measles, increase in mumps. And the reason for this is because we see a lot more people coming into the United States who've not been vaccinated from other countries, coming in from other countries who have not been vaccinated, or people in the United States who've decided not to vaccinate their children for whatever crazy, insane, moronic reason that might be. So if this young child shows up, like 4 years old, and they are in pain, screaming, and you can tell there is inflammation of the testes, and you find out that the family just immigrated from Eastern Europe or someplace, you might want to keep in mind this might be the mumps virus. So mumps virus, orchitis, inflammation of the testes, orchitis, inflammation of the testes, think mumps virus or anything else. Okay, sticking with the infectious disease theme, we'll go with the sexually transmitted infections. And again, it's very common when learning anatomy and physiology. In the male reproductive system, we often include the sexually transmitted infections simply because the male reproductive system is so simple. Although I can't seem to get the words out today. The male reproductive system is so simple that it doesn't take much time to review. So let's talk about some common sexually transmitted infections. The first one, of course, is acquired immunodeficiency syndrome. Acquired immunodeficiency syndrome, or AIDS. This, of course, is caused by the human immunodeficiency virus. There's no cure for this. There's only treatment options. So in a patient who is HIV positive, we make a diagnosis of AIDS when two criteria are met. The first is that the patient has some infection that most of us wouldn't have, something that most of us would easily fight off. So some opportunistic infection would have to be present. That's one of the criteria that need to be met. The second is that their helper T cell count is below 200 cells per cubic millimeter. When those two criteria are met in this patient with HIV, now we say the patient has the disease AIDS. And typically the opportunistic infection is going to show up first. So what we're waiting on is we're watching their helper T cell count. Once it goes below 200 cells per cubic millimeter, then we say the patient, because those two criteria are met, basically simplifying a little bit, but because those criteria are met, now we say the patient has the disease AIDS. There's no such thing as full-blown AIDS. That is just an exaggeration, like saying someone is full-blown pregnant. But you'll hear people, unfortunately, even in the medical community, use that term. It just is not correct. Going to something a little more simple now, chlamydia. Chlamydia is caused by a gram-negative coccus called Chlamydia trachomatis. Chlamydia trachomatis is the single most common sexually transmitted infection, and it is often asymptomatic in both men and women. They might not even know they have it. They might have no symptoms of it, which is why it's so common, because if a person doesn't have any symptoms, they're not going to go get checked out. That kind of makes sense. Now, the thing about Chlamydia trachomatis causing this disease, it's very simple to treat. It's a bacterial infection. So we're going to treat it with an antibiotic. And something like doxycycline will work just fine for this. But there's an even better treatment, and that is one big dose of azithromycin, the same macrolide antibiotic that's in a Z-Pack, except in this case, it is one big pill, 1,000 milligrams. So 1 gram, a whole gram of azithromycin in one pill taken all at once. The good thing about this is compliance. We don't have to worry, is the patient taking their medicine like they're supposed to? It's just, we could literally watch them take it in the office. Say, here, take this pill, done. 1 big gram, and it's done. But of course, then they're going to have their partners, they're going to have to get treated as well. Otherwise, they'll just keep giving it back and forth and back and forth and back and forth. The next one that you'll hear about is a sexually transmitted infection called gonorrhea. It's the third one I have on my list here, but it's number one in your hearts, gonorrhea, caused by a gram-negative diplococcus called Neisseria gonorrhoeae. Now this, in men and women, they have very similar signs and symptoms. There's often a yellowish or greenish colored discharge, and they'll complain about painful urination, like a pain or a burning upon urination. The good news is this is just a bacterial infection. So how are we going to treat it? Well, we're going to treat it with an antibiotic. And typically, it is an intramuscular antibiotic, something called ceftriaxone, but it's one injection. And that's it, they're done. However, if we test someone and they are positive for gonorrhea, not only do we treat for gonorrhea, we also treat for chlamydia. If the patient is positive for gonorrhea, we automatically treat for chlamydia as well. That's how common chlamydia is. Don't even have to test for it, just automatically do it. So the good news is, best case scenario, we give them one big shot of ceftriaxone, we give them 1 big gram of azithromycin, and they're done. And why is that important to know about? Well, not just because these are very, 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 did I mention they're very, very common? Yes, they're very, very common sexually transmitted infections. So it's good to know about because the treatment options are very simple. But also, you may have heard of a condition called pelvic inflammatory disease, or PID. This occurs obviously in women, and this is when an infectious agent ascends into the uterus and down the fallopian tubes and can create scar tissue and can cause a lot of pain, especially during sexual intercourse, but just other times as well. Can cause infertility. And then something that not enough women know about, because when they hear about pelvic inflammatory disease, they often know about the potential for infertility, and they often know about the pain that comes with having this. But what they often don't know is that pelvic inflammatory disease kills about 150 women a year. And the worst part is a lot of the pelvic inflammatory disease is caused by chlamydia and gonorrhea, which can be easily treated. So let's get those numbers down by taking care of these things early, making sure people get treated for these things early, because then it's going to decrease the likelihood of that leading to pelvic inflammatory disease. And there's something that happens when we do a bimanual pelvic exam on a female, where we use one hand, we're going to manipulate the cervix. When that happens, the pain in a woman who has pelvic inflammatory disease is so sharp and sudden and intense, she's going to leap off of the exam table and grab onto the light fixture overhead.
Sir, so this is taking place in the pelvic?
Yeah, in the uterus, fallopian tubes, and even into the pelvic cavity, into the peritoneum.
Sexually transmitted as well?
No, I'm saying that these two diseases can lead to pelvic inflammatory disease.
Oh, okay.
Other things can as well, but these two are the most common causes of this.
Okay.
And manipulating the cervix, causing this pain in this female, creates what we call the chandelier sign, meaning she's going to leap off the table and grab onto the light fixture. She's going to, jump out of the way so quickly. Now, it's a bit of an exaggeration, but it is actually a medical term, the chandelier sign, from the sudden pain of pelvic inflammatory disease. So those two are common sexually transmitted infections. that can lead to pelvic inflammatory disease, as well as other problems also. But the next one is one that's kind of making a comeback a little bit, called syphilis. And syphilis is a bacterial infection. It falls under a category that we call spirochete because it has a very spiral shape to it. It almost looks like a little spring. And they're very, very thin, so we can't even see them under a regular microscope. We have to use something called dark field microscopy just to be able to visualize these things. But this spirochete that causes syphilis is called Treponema Pallidum. And syphilis shows up in different stages. And the first stage of syphilis typically shows up as a painless ulceration or painless canker on the genitals. And I often liken it to looking like a cigar burn. That's kind of what it looks like has happened to this person on some area of their genitals. But the person will say, it's ugly, but it doesn't hurt. And that's a big clue, because the things that can cause a painless, ugly ulceration in the genitals, the list is very, very short. So you could make this, a person can make this diagnosis over the telephone just by having the person describe it to them. Now, the bad news about this painless ulceration is that it goes away after 10 days or 14 days. And I know you might say, well, that doesn't sound like bad news if it goes away. Now, the bad news is the ulceration goes away, but the syphilis is still there, still in the body. And the problem is that, hold on. The problem is that the patient thinks that it went away, so the problem is over. So they might not seek treatment, whereas they would have before. Now might think, well, whatever it was, it's gone now, so I don't have to worry about it. And that's the problem, because this is only the first stage of syphilis. Yes, what is your question?
You just cleared it up right there.
Yes. Then it goes into a second stage. This can cause problems in the joints, in the bone, in the skin, in the cartilage. We could find skulls that have areas of demineralization that almost look like they were chewed up. Of course, it's not bacteria chewing it up, but that's what it appears. That's what it looks like. And a common thing that could occur, because it destroys cartilage, is the nose would be destroyed. And the nose would look like it just sort of fell off. That's what it would appear. Now, how much does that matter to a person that their nose is missing? Think about the last time you had a pimple on your face, a little tiny pimple, and you thought, well, I'm not going outside looking like a monster. People are going to look at this giant hill on my face. Forget it. I'm deformed. So, you know, I mean, we know people we know ourselves by our faces. We know other people by their faces. So having such a huge deformity on the face could cause the patient to not want to really spend a whole lot of time, outside of the house. How long has syphilis been around? This is one of the questions I often get when I talk about chlamydia, gonorrhea, syphilis, is, well, where did that person get it from? And I say, well, they got it from the person before them. Well, where did that person get it from? Well, they got it from somebody else. Well, where did that person get it from? They got it from somebody else. Well, where did it start? I don't know, because I'm not that old. Syphilis has been documented back to the 1500s, early, like 1502. They were calling it syphilis back then. It has been documented since that time. And because in Italy since 1502, it's been documented since that time, a lot of people thought, well, it must have come back from the New World when Columbus set sail in 1492, and I'm going to use air quotes, discovered America, that they must have brought it back with them. That was the prevailing thought for a long time. However, about 3 years ago, there was some skeletal remains discovered in England, and the bones of those skeletal remains have lesions that are consistent with syphilis infection. So we kind of assume that it's probably dated long before the 1500s, because those skeletons were 1,000 years old. So it probably dates before the 1500s. Maybe they were just calling it something different before that time. But this has been around for a long time. The interesting thing that comes from this, though, is plastic surgery, or the attempts at plastic surgery. I should say, in this case, reconstructive surgery. And some early examples of reconstructive surgery to the nose date back 2,000 years almost. You can see this in an old Indian poem about a woman who was promiscuous or cheated on her husband or something and had her nose cut off. It was a common punishment. And then tried to have a reconstructive surgery and created this pedicle from the forehead. But in the 1500s, to replace a nose that was lost or something that would resemble a nose was still a difficult process. You know, they did not have vascular surgery back then. So you couldn't just take material from one part of the body and stick it on another part of the body and hope that it stayed, because it wouldn't. You would have to create some sort of blood supply first. So in the early to mid 1500s, there was this doctor that created a type of pedicle that would come from the arm up to the nose. So they would attach skin from the arm. So half of it would be attached to the arm still, the other half would be attached to the nose, and they would have to stay like that for weeks at a time. It's a really interesting way they created this graft, sort of a skin graft. But I digress. So this has been around for a long time, and that's just the second stage. Then the syphilis goes into a latent stage where you don't hear from it for a while. And then it goes into a tertiary stage, the third stage, where it creates neurological problems, can cause things like lunacy, as well as death. And this is what has been reported to have killed Al Capone, who was the original Scarface gangster back in the 1920s and 30s Chicago. The thing about syphilis is it is just a bacterial infection, and it is still very, very, very susceptible to penicillin, specifically penicillin G. So one intramuscular injection of penicillin G is typically enough to fix this syphilis. So it has been a bit on the rise over the past couple of years. That's all I have to say about syphilis. The next one is trichomoniasis. This is caused by a protozoan. This is not a virus. This is not a bacterium. This is like an amoeba, and it's called Trichomonas vaginalis. This is what people refer to as trick, because nobody wants to say trichomoniasis because it's too big of a word. Trichomonas vaginalis, this protozoan, creates this infection that is usually asymptomatic in men, so men don't know they have it. But in women, it creates a very obvious, frothy, like a bubbly odoriferous discharge. It's easy to spot when you see it. You know it's trichomonas. Then it also creates these little pinpoint hemorrhages on the cervix called a strawberry cervix. You can see as well with a speculum. But the discharge is usually what's first noticed. So of course, this isn't a bacterium, so we can't use an antibiotic. Don't use an antiviral. We use an antiprotozoan to get rid of this. But that works, and it's something, again, partner needs to be treated with, even though that partner might be asymptomatic. I'll just keep giving it back and forth. Another one to discuss here is genital herpes. Genital herpes.
Sir, I don't know if you know, but if you are on a different slide, it still has the penis slide up there.
Yeah, I hadn't moved on to anything.
Okay.
Yeah, in fact, that's why I just got rid of it, because there's no reason to keep showing slides. Now, this is not on a slide. I'm just talking about these things. And I'm talking about them not necessarily because I'm going to test you on them. No, I don't think so. Kind of thing with it, though, there is something interesting before I move on. There's something interesting about when I talked about chlamydia and gonorrhea. And that's gonorrhea is also known as the clap. And I mean, I know a lot of these also have other names they go by, but gonorrhea is the one that's often referred to as the clap. People think chlamydia is called the clap because they sound kind of similar. They both begin with that cl sound, but it's actually gonorrhea. And nobody knows for sure how it got the name, but the most accepted reason is because of a discovery made in the late 1800s, mid 1800s in Paris by a doctor who saw these patients who had these same signs and symptoms, these discharge, green, yellowish discharge, pain during urination, etc. And he saw that in women who were prostitutes, and of course in men who would visit the prostitutes, specifically in an area of town that was what we would call a red light district, or an area of prostitution. And that area of Paris was called Le Clapier. So the doctors termed the disease Médecins de Le Clapier, or something along those lines. Médecins Le Clapier. Something like that. Now, of course, when US soldiers were deployed over there in World War I and World War II, and they ended up going to these areas, and they ended up visiting these areas, and they ended up with these same signs and symptoms, and they would go to the doctors, and the doctors there would tell them, you have the disease of Le Clapier. The Americans, just like Americans do, abbreviated it and called it the clap. That is the most accepted the most accepted reason why it got the name the clap. But in fact, it is gonorrhea, not chlamydia. So just an interesting side note on that, because you will hear people mixing that up a bit. You don't want to mix that up. Okay, where was I going to? Oh, genital herpes. Genital herpes will show up as these vesicles like little pimples, but instead of having pus in them, they're clear fluid filled, and they are painful vesicles. The patient will tell you these things hurt, kind of like a cold sore hurts. And just like a cold sore, they reoccur. They come back every so often. Except, of course, with genital herpes, they're occurring on the genitals. And there's no cure for this. There's only treatment. But they can occur on areas that aren't covered by a condom. So even when people think they're being safe, they could still actually contract this, which is unpleasant. This is genital herpes. This is herpes simplex virus type 2. Herpes simplex virus type 1 is a type that occurs around the mouth. That's the one that causes cold sores or fever blisters, whatever you want to call them. That's herpes simplex virus type 1. That's very common. About 95% of people in the United States have antibodies to that, meaning they've at the very least been exposed to that. But genital herpes is herpes simplex virus type 2. These are two different viruses. One likes to stay up here, one likes to stay down there. They don't like to switch. But people often ask, can they switch? Yes. Can type 1 be found down there? Can type 2 be found up there? Yes. So a question that often comes up is, what if a person has herpes simplex virus type 1, the one found around the mouth, oral area, and that person performs a sexual act on their partner? Can that partner then get herpes down there? The answer is yes. However, that doesn't mean that the partner now has herpes simplex virus type 2 simply because it's on the genitals. It means they have herpes simplex virus type 1 that is found on the genitals. So it hasn't changed into the different type 2 virus. It's still type 1 virus, but it's down there now. Okay. How bad is that? It's actually not the worst thing, because it will clear up. It will go away. It'll probably return at least once, maybe twice at the most. And then it'll never return again after that. And in fact, that person will now be immune from herpes simplex virus type 1 down there again. So it's not the worst thing in the world. But just because the person had type 1 on their mouth and they performed this act, it would not cause the person to have genital herpes type 2. It would just cause that person, the partner, to have type 1, but down there. I know it gets a little confusing, but they're two different viruses. They don't like to switch. They don't like to change places, but they can in some instances. So the treatment for this.
So if they're, sir, so if they're immune to it now,
Down there.
Yeah, down there, from catching it down there.
Right.
Would they be immune to it from catching it near the mouth as well?
No.
Okay.
No.
I have a question.
Yes.
In order for you to pass it along, it has to be a flare-up, right?
Yes. Now we'll
I mean,
say
it has to be active.
We'll say an
Outbreak. Okay, yes.
rather than a flare up, because flare up makes it sound like it's at its peak. When an outbreak, because in either case we're talking about sort of the start of this showing up again, these lesions showing up again, and the height of these lesions, and then the decrease, decline, and the going away of the lesions. The thing is, yes, it only passed on while the patient is having an outbreak. Unfortunately, sometimes people can have an outbreak and they just don't know it yet. There's only like one little lesion that has started, although often the patients will describe a sensation in either type 1 or type 2 of what's called paresthesia, where they feel this sort of tingling sort of sensation coming on. If you ever had a cold sore, they'll say, I felt it the day before. It was like I could feel it was numb or tingly right here, and then the next day it started to show up. So they could describe that, but it can still happen where the person might not realize they're having an outbreak, like there's only one little thing showing up, or they're on the downside of it and they think it's over. They think they're no longer active. They're not having an active outbreak, when there really is one lesion that still is part of that active outbreak. And that's enough to pass it on. Or when people think, like I said before, they think they're being safe, so they use a condom, not realizing that there's a lesion that's not being covered by this condom or not being protected by the condom. So it can still happen. There's commercials that talk about the medications for herpes simplex virus type 2. And they will say that these medications are going to decrease the timeline of the outbreak and then increase the timeline between outbreaks, which is exactly what it does. And the commercials, they'll say, I don't have herpes, but my partner does, or something along those lines. And they're saying, you know, this is helping us to keep from transmitting it. The reality is, there's a good possibility it's going to happen eventually anyway. You know, people can be really safe for 10, 15 years of having sexual intercourse, and being really safe meaning trying not to have a baby. But no matter how much they try, there's still that possibility. So even when people are really trying to be careful and really trying to be safe, there's still that possibility that, yeah, it can happen. So it's something that, you know, people need to discuss with partners. And that's the unfortunate thing about this. I mean, they have to discuss with their partners pretty much forever. And there were lots of times where I had to make a first-time diagnosis on young people, 19, 20 years old, who didn't know what it was. It just showed up. And, you know, talking about their history, they said, well, I did meet this person. I didn't know him really well. We were just at a party, we were drinking, smoking, and the one thing led to another. They even say things like, I didn't like him that much, or it's like, well, now you get to think about that forever. And when you meet somebody, you know, those are things that you have to discuss with them so that you don't keep passing this stuff along. That's unfortunate.
Dr. Sturgeon,
Yes.
is chickenpox a form of the herpes virus?
It falls under the same category, same family. I can put it that way. It falls under the same family, but it's definitely a different virus. I mean, obviously, it is airborne, so it is easily transmitted that way. And it doesn't, in the early stages especially, it doesn't cause pain. It causes more of an itch, and then it's pretty benign otherwise. And a good way to think of it as it is part of a family. So if you know a family, and we probably all know a family or a family of a family, where there's one family member who is just a terrible person, commits crimes, goes to prison, maybe even murders somebody, just because they're part of that family doesn't mean everybody in that family is as bad. So you gotta kind of think of it, when I use the term family of viruses, there's a big umbrella there. So simply because you see that last name, don't automatically think, well, they must be, you know, the same. They must be equally bad. Not really, but they do have things in common. I mean,
Okay, thank you.
the most obvious is that, you know, it erupts on the skin, shows up that way, nothing else. And that it is going to include its nuclear information into the cell's DNA. We see that also with human papillomavirus, HPV. HPV causes warts. And they've identified around 100 different serotypes, or what people would call strains of HPV. And they cause warts on like the hands, on the feet, on the genitals. And there's at least 2, probably 3 strains that cause cervical cancer. Those are serotypes 16, 18, and 31. Probably 31. 16, 18, and probably 31. Those serotypes of HPV cause cervical cancer. Those are the ones that we're worried about. We're not really worried about warts anywhere else, although warts aren't terribly attractive, but they are just, these growths from this virus, and most of the time they can be burnt away or frozen away or cut away, removed in some way. But we are worried about the strains that cause cervical cancer. And this is a disease, of course, that can be transmitted from person-to-person contact. That's how people get warts. You don't get warts from touching frogs or toads. You get warts from HPV, which is called human papillomavirus. So as to protect against the strains that cause cervical cancer, there is a vaccine, you've probably heard of Gardasil, that protects against this. However, I suspect there'll be a time in the future where people will go to their doctors with a wart on their hand, and then they'll ask, what is this from? And the doctor will say, oh, that's from human papillomavirus. And they'll say, but I don't understand. I was vaccinated against human papillomavirus, not realizing that they were vaccinated against the strains that cause cervical cancer, but not against the strains that cause warts. Because again, we're not really worried about those. We're not going to put a whole lot of time and effort into discovering something that is going to, prevent just regular warts from happening. So those are some sexually transmitted infections. I think I covered some of the basic ones, which I think is an important thing to do, quite frankly. And it also makes the discussion of the male reproductive system a little more interesting, rather than just how quick it is, simple. Unlike the female reproductive system, which we're going to talk about very shortly. But first, let's take a break. We'll pause for a few minutes. Okay, so let's go into some female reproductive system now. So we'll pull up those slides in just one moment. So you should be able to see these slides here now. Okay, this is 25. There we are. The female reproductive system produces the gametes, the eggs, or the ova. The sperm is also a gamete. So when one gamete, like the sperm, meets another gamete, like the egg, they create something called a zygote. It's a brand new cell, it's never been seen before. The female reproductive system not only, is responsible for creating the egg, but also responsible for protecting this and giving nutrients to this growing baby. The essential organs of the female reproductive system are considered to be the ovaries. Those are the gonads, just like the testes were the gonads in the male. And then all these other parts fall under accessory organs, and you'll notice that includes the mammary glands. So once again, we have actually a really nice and simple diagram of parts of the female reproductive system. We'll start by looking at this part right in the middle called the uterus. Now, it's hard to see from this angle, but it is sort of, it looks like an inverted pear, an upside down pear shape. You're seeing it from a side view. Notice that it is tilted toward the front of the body. That is what we call anteflexion. And it is sitting right on top of this triangular shaped structure here. That is the urinary bladder. And you can see the urethra leaving the urinary bladder there. So the uterus is this muscular structure. Notice how thick these walls are of muscle. That is the place where the baby is going to grow inside of there, which means that is going to have to stretch. It doesn't grow, it stretches. So that muscle becomes thinner and thinner as it stretches and stretches more and more. And that uterus starts out overall length of about 3 inches, which is not very big, considering eventually it's going to hold a baby and a placenta and amniotic fluid. Starts out only about 3 inches in size. Then after she delivers the baby and placenta, it's going to shrink back down to almost its original size. It doesn't quite get back to where it was when she was nulla gravida. Nulla gravida means she's not pregnant, not pregnant now, never been pregnant. That's the nulla gravida size, 3 inches. And you'll notice the neck of the uterus here is called the cervix, which is right into that fornix of the vagina. And the vagina continues all the way out. It is a collapsed tube to the outside world. And then you can see here one of the fallopian tubes, and then one of the ovaries. Let me get those in the, there we are. The ovary you can see there, and the fallopian tube you can see. Notice the ureter coming down here as well. So the ureter, notice the proximity to the fallopian tubes and the ovary. This is something that I would watch for back when I was first learning how to do laparoscopic tubal occlusions and tubal ligations. One of the first things I was taught and I learned how to do was to look for those ureters, the ureter, of course, coming down from the kidney to the ureter bladder. Once I was inside of the abdominal pelvic cavity with my little camera going in to perform this procedure, the very first thing I would do is I would locate the ureters just so I would know to stay away from them, because I wouldn't want to accidentally nick or cut those. So before I did anything else, I would locate those ureters. You can see the proximity to where the fallopian tube is, for instance, that is going to get cut or in some way manipulated. But I digress. Okay, you can see some of the external structures of the vulva, including the labia majora and the labia minora, and the clitoris, which is an organ of sexual response. And we'll see a little of each of these in a little more detail. We'll definitely talk about the uterus, fallopian tubes, and ovary in much more detail. The perineum, once again, is that area between the vulva and the anus. But looking at the top, we see this area called the mons pubis, which usually would have pubic hair there. The mons pubis is a fatty pad that sits on top of the pubic symphysis and the 2 pubic bones coming from the pelvis. And that fatty pad offers some cushioning. You can see the clitoris, the glands of the clitoris, and is somewhat covered by the prepuce or the foreskin. The labia majora are the outer thicker lips that tend to have pubic hair. The labia minora, or labia minus here is singular. It has the thinner inner lips that do not have pubic hair. Notice the orifice of the vagina, also known as the introitus, which is how you will hear me refer to this. The introitus of the vagina, or the vaginal introitus, is the opening. So the vagina is actually more internal. It's not considered really external, it's considered an internal component. What you see here is collectively referred to as the vulva. And notice the opening of the urethra, the external urinary meatus, or urethral meatus, between the clitoris and the vaginal introitus. So if we go back to this picture for just a moment, and we look at the urinary bladder here, the triangular urinary bladder, you can see that very short urethra. Remember, that's 1 to 2 inches long, coming out to the outside world. Here's the urinary meatus, the opening, and the vagina and the vaginal introitus here. I point this out because sometimes women think that the urine comes out of the vagina, but it does not. It comes out of a totally different place. I know to some women that might sound, I don't know, somewhat, I don't want to say ridiculous, but for lack of a better phrase, some women don't understand there's a difference there. And I've had students who were not only women, but were mothers. In other words, they had given birth, yet they still didn't completely understand their anatomy in this area. And there are people who believe, women, young women especially, who believe that if they urinate right after sexual intercourse, it will push all of the semen and therefore all of the sperm out. But of course, this is coming from a totally different area. So no, that is not the case. The reason we recommend urination right after sexual intercourse is because of bacteria that's right around that opening of the meatus, of the urethra. During sexual intercourse, that bacteria can get pushed inside, which can increase the likelihood of the bacteria making its way up the urethra and into the bladder and creating a urinary tract infection. So that's why that is recommended. Okay, I talked about this a little bit. One thing down at the bottom here, this area of the perineum can often tear during childbirth. And when this baby is coming through, we can see the vaginal introitus compared to the head of the baby, and we can see where in this area the head is pushing, and we can get a general idea of if and how much of this area of that introitus is going to tear. That's not uncommon for tearing to occur. The problem is we do not want it to tear down into the rectum or the anus. If a tear occurs down into the rectum or the anus during childbirth, that is a difficult surgical repair that might never have complete functionality again. In other words, it can cause the mom to have the inability to maybe hold her bowels like she should. There might be some incontinence. So we want to not necessarily stop tearing from occurring, but we might want to direct the tear. The way that we direct the tear is a procedure called an episiotomy. A little bit of tearing is okay. In fact, the tear will actually heal better than an incision will. But if we suspect that there might be excessive tearing that could lead to tearing into the rectum or the anus, then we want to direct the tear and say, not say, don't tear at all. We're going to say, you're allowed to tear, but you have to tear this much in this direction. And then that's acceptable. And that usually will help decrease the likelihood of a tear into the rectum or the anus. And then, of course, sewing that back up again starts on the inside with the bulbospongiosus muscles. Those are usually the first ones. That's where the real integrity, the strength of the suturing begins. And then as you work your way out, suturing areas together, the skin just sort of falls together where it's supposed to be. So those last couple of sutures that we put in the perineum and the skin, they're just kind of holding skin edges together. They're not the most important by any means. I mention this only because of how many times I've had women say that they lost some of their stitches and they thought that they were going to split open, which is just not going to be the case. It would just cause the skin not to close completely or as cleanly, but it's not a big concern like the person's going to split in half. Okay, let me just go right to this picture to speed things along a little bit. Here is a really nice image of what the uterus looks like with the fallopian tubes and coming into the vagina. Notice again, the uterus kind of has sort of an upside down pear shape to it. The fallopian tubes are connected medially to the uterus and then extend laterally out to where they're suspended next to the ovary. They're not connected to the ovary, but they're suspended next to the ovary. You'll also see that we have a ligament that connects the ovary. We also have a ligament that connects the uterus. We also have another one for the fallopian tubes. But then there's one ligament that links everything together, and that is called the broad ligament. So even though each of these components has their own ligament, there is this one called the broad ligament. It kind of looks like a bat wing. And of course, it would be on either side. You can't see it on this diagram because they cut half the diagram there, but it would exist on both sides. It would kind of look like a wing. But the broad ligament is the one that connects everything together. I simply mention this because when we do a pelvic exam or we're doing a bimanual pelvic exam where we're manipulating the cervix anteriorly, so the uterus sort of comes up towards the surface of the abdomen and we can palpate it, it pulls everything up with it because, of course, everything's connected that way. You can also see the cervix is the neck of the uterus where it enters into the vagina. And there is an opening right from the vagina into the uterus. And then there's sort of another little opening. These are called the cervical os. There's an internal os and an external os. It is labeled, okay. This is a very, 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 very small opening, but it is an opening. And even though the vagina is a collapsed tube, it is still open at its distal end to the outside world. It's collapsed, but it's still open. Okay. So there's an opening to the outside world. And of course, we know that anytime there's an opening to the outside world, there's going to be some kind of mucus that is created to help trap things so they don't make their way in towards the rest of the body. And we're going to find that in the vagina as well as in the uterus and even into the fallopian tubes. But I want you to be aware of that from the outside world going into the vagina, there's no doorway or membrane. Going through the cervical os, even though it's a very tight little small opening, it's still an opening. And that leads into the intrauterine cavity, which then leads into the fallopian tubes, which then opens up into the pelvic cavity. So her internal pelvic cavity technically is open to the outside world, which is certainly different than the male. Okay, geez. Which means there's a greater likelihood that things could ascend all the way up through the uterus and into that pelvic cavity, into the peritoneum, and cause infection. Okay. You could also notice with the uterus, look how thick the muscular part of the uterus is, called the myometrium. The myometrium is the thick part of the uterus that makes up most of the uterus. Then there's a thin lining called the endometrium on the inner side. That endometrium is really important because that endometrium is actually going to change. It's going to increase and increase and increase and increase in thickness as it prepares for a baby or a fertilized egg that's going to turn into a baby. And if that doesn't happen, then that extra thick endometrial lining is lost and it goes back down to its basic minimal endometrial lining, which next month will grow and grow and go through that process again. The rounded dome-shaped part of the uterus is called the fundus, which we saw with the stomach had a rounded dome-shaped part called the fundus. We saw with the urinary bladder had a rounded dome-shaped part called the fundus. So the rounded dome-shaped part of the uterus is called the fundus. When she is pregnant, we are going to measure with a tape measure from her pubic symphysis all the way up, and we're going to feel for that uterine fundus. And at about 20 weeks pregnant, the top of that uterus should be right about approximately her belly button. At about 20 weeks pregnant, should measure up about 20 centimeters or more than that, up to the top of her uterus, 20 weeks, yeah. And then we expect to see about a centimeter growth per week for the next up to about 36 or 37 weeks, approximately. But just to give you an idea of why you'd want to know what that is called. What's demonstrating here in this ovary is a mature egg in a follicle is rupturing. The egg is released, and the little finger-like projections called fimbriae of the fallopian tube are going to help release the egg from the follicle and direct it into the first part of the fallopian tube, kind of a funnel-shaped area called the infundibulum. And that is going to bring it into an ampulla we'll see a little bit later on. Oh, actually, it might be over here. Yeah, there it is, the ampulla. So it is in that area between the infundibulum and the ampulla. That's usually where the egg would get fertilized. You can see the fimbriae here. Now, mind you, these fallopian tubes are about 4 to 5 inches in length. And the time it takes for that egg, once it is released, to travel down that fallopian tube and into the intrauterine cavity is going to be about 5 days. And the way that it gets pushed down along there is muscle in those fallopian tubes, like we saw in the arteries, like we saw in the gastrointestinal system. It's going to create this wave-like motion. The muscle that is inside of these walls is going to propel this egg. And there's also cells that have cilia. And you'll remember that cilia sweep. So they're going to help sweep this egg down into this intrauterine cavity. Okay. Oh. Ovarian follicles contain the developing female sex cell. So inside of the ovaries, there are things, these compartments called follicles. Now, when a woman, or no, let me rephrase that. When a female is developing in the uterus, in other words, mom's pregnant and she's having a baby girl, when that little baby girl is developing inside the uterus, that little baby girl is going to develop about 250,000 eggs already, but they're not in a mature state. And by the time that little baby girl is born, she's going to have about 25,000 eggs, but still in an immature state. And then from puberty to menopause, she is going to release 1 egg a month, about 400 to 500 times over her lifetime from puberty to menopause. So of the 250,000 that started out, about 25,000 are there when she's born, and about 400 to 500 are actually released over her lifetime. And they start out in these follicles. And the follicles will then eventually rupture and release that egg. Okay. The process that results in formation of the mature egg is called oogenesis, or it's pronounced oogenesis. It is not pronounced oogenesis, although I pronounce it oogenesis because I like that better. I think it sounds better, but that's wrong. So don't pronounce it like I do. It is pronounced oogenesis or oogenesis. Either of those pronunciations are correct. Oogenesis or oogenesis, the production of these eggs. Ovulation is the release of the egg from that mature follicle. This happens on approximately day 14 of the menstrual cycle. So let's see, if we think of the menstrual cycle as starting on day 1 with the first day of her last menstrual period, if that's day 1, then on approximately day 14, the egg is released, which means if she is trying to get pregnant, she's going to want to know when ovulation occurs. And that's the time to start trying, because it could take the sperm a while to meet the egg. Once the sperm are released, they could take anywhere from, I've heard as little as a half hour up to 3 days, up to 72 hours to reach the egg. But has to be released first. So if you're not sure when that happens, keep track, first day of the last menstrual period. Also, if you take your body temperature every morning at the same time and write it down, what you might notice when ovulation occurs is that there'll be a spike in the temperature. Body temperature will increase a bit. Ovaries also create hormones like estrogen and progesterone, FYI. So here is that ovary, starting out with these tiny little primary follicles and the surrounding granulosa cells. As the egg is maturing and the follicle is maturing along with it, that follicle then becomes mature, which is what you see here is the Graafian follicle, which then will rupture. So every month, about 5 of these will mature, but only 1 will rupture. That's what's supposed to happen, at least. And then that those fimbriae help to rupture this, and they help direct that egg into the first part of the fallopian tube. And then you'll notice that follicle fills up with fat. See how it's starting to get a little yellow lining in it? And then it becomes what we call the corpus luteum, this fat-filled follicle, which is then going to produce progesterone. and then eventually wither away to the corpus albicans. Like I said, normally the uterus is in that anterior flexion position, tilted forward, but it could tilt in any sort of arrangement or variety along the spectrum, including completely backwards, which is called retroflexion, which would certainly make it more difficult for baby to develop in that area, or even implantation to occur. Okay, I talked about that, talked about the cervix, talked about I didn't talk about the outer layer too much, but I'm not going to worry about that too much. The endometrium, this is the layer that is going to grow, become thicker, and then get lost. Myometrium is the thickest part. The uterus is the place. Yes.
With the endometrium, is that where what is it called? Oh goodness.
Is it a disease?
Yeah, the endometria.
Endometriosis?
Yes, is that where that occurs?
Ironically, no. Let me show you what I mean by that. I'm not drawing this to scale. Here's the uterus. We'll throw in some fallopian tubes over here, some more over here, a couple of ovaries. The endometrium is the inner lining. This is the lining that undergoes changes every month, that grows thicker and thicker and thicker, and then gets lost, grows thicker, 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 then gets lost, grows thicker, 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 then gets lost. So that lining is meant to do that, because when it gets thicker, it's going to create a nice place for that blastocyst, for that fertilized egg to implant. If there's no fertilized egg, the lining gets lost and leaves through the vagina. That's what she would call her monthly period, or we'd say the menses. Sometimes some of that endometrial tissue can end up in places where it doesn't belong, like inside of the fallopian tube, or on an ovary, or on the outside of the uterus, or even on the wall of the pelvic cavity. That is what we call ectopic tissue, meaning it is in a location where it's not supposed to be. It is supposed to be in here, but for some reason, it is not. Now, the problem with this ectopic endometrial tissue is that it is going to go through the same changes as this inside the uterus, which means it's going to increase in size, and then the blood supply will get decreased, which means it will then sort of die off and create these little patches of brown area. We actually call those chocolate cysts. But this is going to cause pain. Hold on one second. This is going to cause pain to occur. So endometriosis is when there is ectopic endometrial tissue. The tissue that is supposed to be inside is, for some reason, there's parts of it that are outside. Now, the question is, why does this happen? Well, we don't really know for sure. However, one possible reason, and sort of the accepted reason, is what we call a retrograde flow. Instead of going out the way it's supposed to, there might be some tissue that goes in the wrong direction and then finds a blood supply and then starts to grow from there. And that could certainly explain why it could end up in a fallopian tube or on the ovary or inside the pelvic cavity, the abdominal pelvic cavity, on the peritoneum. but it doesn't really explain why sometimes it can be found in the thoracic cavity or even the cranial cavity. That's not really clear, but that's what endometriosis is. And the problem with this is because these little tiny areas, these little tiny chocolate cysts now can be found all throughout here, there's no way of going through and just removing all of them because you can't really find all of them. So what oftentimes has to happen is they'll remove the ovaries and sometimes remove everything. Do a hysterectomy and a bilateral salpingo-oophorectomy, taking out everything. And of course, now the person has to be on medication. They have to be on hormone replacement therapy. But this is sort of like the last case scenario. They often start with trying to use birth control to regulate the growth of the tissue. But the radical and maybe like the final outcome might have to be total removal of all of this in order to have this woman not live in discomfort from the ectopic tissue. But that's what endometriosis is. It's ectopic endometrial tissue.
Dr. Surgeon, if you have endometriosis, could it ever heal?
I do not. I'm a boy. In some cases, perhaps if it was small enough, maybe. It really depends on the amount and the location of where it is found. It probably is not going to, it would be less likely for it to get completely better. It'd be more likely for it to stay the same or get worse. But I suppose it could happen, yeah. Who else had a question? Oh man.
I have a question. Is
Yes.
the way the ectopic tissue travels, is that the same way ovarian cysts form too?
Oh, that is such a good question. That is such a good question. Let me tell you why. The follicle that matures with that mature egg in it, that follicle that's going to rupture and release the egg, if that follicle doesn't rupture and that mature egg is just sitting inside of there, then the egg will dissolve and that follicle will fill with fluid. And that's what we call an ovarian cyst. And I say it's a really good question because going back to what I said earlier, that she is going to release 400 to 500 eggs over her lifetime, which means that process that I talked about earlier, where these eggs have to mature, the follicles mature, and it has to rupture, and the fimbriae are going to come along and help that to rupture. That has to happen correctly 400 to 500 times over her lifetime. The chances that at least one of those times it not work perfectly, that one of those follicles don't rupture and that fills with fluid and becomes an ovarian cyst is really, really good. It's really likely that it won't happen perfectly at least one time over her entire lifetime. That means if we were to look at every woman who died, who lived a normal life into her 70s, 80s, 90s even, and we autopsied them and looked really closely at their ovaries, chances are we would find that many women had ovarian cysts, may have lived with them their whole entire life, didn't even know they were there, didn't cause any problems, so they didn't even notice that they were there. That does not mean that ovarian cysts do not sometimes cause problems. They can. But what I'm saying is it's very, very common and very, very likely that it happens even more than women realize. But that's how ovarian cysts occur as a result of that follicle not rupturing and then filling up with fluid. Now that's different in someone who has polycystic ovarian syndrome or Stein-Liebenthal syndrome.
Follow-up question.
Where they have multiple cysts. Yes.
If the cyst tours before and you had to get surgery to remove the cyst. Could it happen again?
Of course.
I don't know. Okay.
Yeah. But could it happen to the extent where it requires surgery? Not necessarily. But yeah, just because a cyst was removed does not mean that a person will never get another cyst again.
Thank you.
Mhm. I'm sorry, that's not that's not what you wanted to hear, I suspect, but that's the truth. That's what I know. The truth. That's what I share. The truth. And I think it's time to take a break. So we'll be right back in just a second. You'll see me again. Let's go on. There we go. That was fast. We are back then, and we are going to continue with the female reproductive system. There are no other questions. You should be able to see my screen right about, I don't know now, probably. Yeah. If conception occurs, conception is the union of the sperm and the egg. When the gamete meets the other gamete and a zygote is created, that is what we call conception or fertilization. Technically, this is when pregnancy begins. Pregnancy begins at the moment of conception, not when it actually implants in the endometrium, but at the moment of conception. So if that happens, then eventually that new fertilized egg will make its way down the fallopian tube, will change into these other cells, eventually becoming what's called a blastocyst. That blastocyst will have a early placenta. It's called the chorion. And that chorion will start to embed into the endometrial lining. That is a big step. So let's just do it this way here. Here's our strangely shaped uterus. Make a big right in here, fallopian tube, blah, blah, blah. Okay. So we have the endometrial lining. That is this normally thin lining that, of course, is going to have a certain amount of blood supply because those are living cells, they need nutrients. And as that lining thickens in preparation of that fertilized egg, making its way down, it's thicker and thicker, there is going to be an increase in blood supply. We have to send more blood there if there's more tissue. More tissue means more cells. More cells means, of course, that there's going to be the need for those nutrients. And our fertilized egg now is going to look more like a group of cells. And it's going to have this component to it that is called the chorion, which will eventually become the placenta. And that is going to embed itself here into the endometrial lining. It is then going to release a hormone which is going to say, hey, we need more blood supply because we are in baby making mode now. And by the way, stop the menstrual cycle, freeze it, because we are in baby making mode. And this hormone is called beta HCG, or just simply human chorionic gonadotropin hormone. That human chorionic gonadotropin hormone that is released from the chorion into the blood, to mom's blood, is then going to circulate through mom's body and is going to be eliminated by the kidneys, which means it's going to show up in her pee. So when she thinks she is pregnant and she goes to the store and buys a pregnancy test, and that little stick that she is going to pee upon, that little stick is looking for beta HCG, because if it is present, that means that this chorion has released it, which means it has embedded, which means she is pregnant. Now, eventually, throughout the pregnancy, the HCG levels are going to diminish. So if she were to take a pregnancy test late in her pregnancy, it probably wouldn't show up as pregnant, because the HCG is then no longer needed, and the placenta makes estrogen instead. But if she takes a pregnancy test too early, there might be not enough HCG, or it hasn't implanted yet. So it'll still show up as negative. So if the pregnancy test shows up positive, then she's pregnant. If it shows up negative, then either she's not pregnant or it's too early yet to know. So let me go through this kind of quickly here. Let's go back to our uterus. Somewhat better uterus. Not so great fallopian tubes. Okay. So what she sees every month for about days 1 through 6 is what's called the menstrual phase. And this is where she's going to lose about 30 milliliters of blood and tissue, some mucus that is lost. Then days, oops, I should start out with this actually. So we'll go back to a very thin endometrial lining. Then days 7 to 13, approximately. Days 7 to 13 is called the proliferative phase. During this time, there's going to be more of this endometrial lining growing here, some blood supply in here. Then days approximately day 14, that is ovulation. That is release of the egg from the follicle. Then days 15 through approximately 26 is called the secretory phase. More and more lining is created because the body is expecting that there's going to be a baby coming down, or a pre-baby coming down, a fertilized egg in the blastocyst. If, however, there is no implantation that occurs, days 27 and 28 are the ischemic phase. Ischemia means we cut off blood supply. Greatly reduce blood supply. If we greatly reduce blood supply, all this extra tissue that is in here is now going to be lost, which is going to happen over the next several days as day 1 through 6 again. So the menstrual cycle isn't something that just happens for a few days 1 through 6 approximately. That's the only part that she sees. The menstrual cycle is a cycle. So she sees days 1 through 6, but there's other stuff still occurring in her body. Again, approximately day 14 is ovulation, the release of the egg. And then if that egg isn't fertilized, then this very important part here happens, days 27 and 28. That is the ischemic phase. Cuts off the blood supply, which means now her period is going to start. Back to day 1 again, losing the blood, the tissue, the mucus, the fluid, etc. What this means is if there was a baby that was in the uterus during this time, if there was a baby growing in here at any stage, if she cut off the blood supply on days 27, 28, then the baby is going to get lost along with everything else. This is why a woman who is pregnant cannot have her period while she is pregnant. Because in order to have a period, she must first have an ischemic phase. And that means cutting off blood supply, which means all that tissue, including the baby, would die. So I should rephrase that. A woman who gives birth to a term live baby could not have had an ischemic phase during her pregnancy. She could not have therefore have had a period during her pregnancy. Although I know that many of you will say, but I know someone who had their period during their pregnancy. They did not have a period during their pregnancy. They may have had bleeding, but the bleeding was probably from the cervix. So it was cervical blood. It wasn't menstrual blood. And oftentimes you'll even hear them say, but it would happen at this right at the same time I would normally have my, yeah, I know, that's a coincidence. This is cervical bleeding. You cannot have menstrual bleeding and then give birth to a live baby. That doesn't happen. So if somebody's having bleeding during their pregnancy, they definitely need to discuss that with their doctor. But the menstrual phase is the menstrual cycle, excuse me, is a continuous cycle. It is something that is always happening. So when a woman says, I'm on my cycle, it's like, well, yeah, you're always on your cycle from puberty to menopause. But what she means to say is she's on her menses, on the menstrual phase of her cycle. I know, nobody cares. Okay. If conception of the unsuccessful implantation of the embryo fails, then the outer layers of the endometrium are shed during menstruation. I talked about the fallopian tubes, sometimes called uterine tubes. I'm still calling them fallopian tubes. The fallopian tubes have layers of muscle, as I said, which is going to help propel that egg down. They also have ciliated cells. I don't know why that's not included in here, because the ciliated cells also help move that egg down towards the uterus, which is kind of important to realize, because remember, the sperm are swimming up against this. That motion is pushing the egg towards the uterus. The sperm have to go up and meet the eggs. They're swimming up against two currents. They're swimming up against the muscle propulsion, and they're swimming up against the cilia, the motion of the cilia. Now, hold on a second. Let's go back to the uterus for just a moment. Where is it? There it is. Okay, so what does the uterus do most of the time? That's a really good question. because you would think that most of the time it doesn't do anything, just sort of sits there and waits for these couple of actions to occur, meaning there's no real motion occurring in it. And a doctor was really curious about this, so he devised an experiment, and this was just a few years ago, where a camera could have been inserted, and of course the patient would have this camera in place for a long time, and they would watch over a period of time what the uterus would do. And after filming this for like 24 hours, what they realized was, looking back on the video, the uterus did nothing. It just sat there. And so this doctor showed his colleagues this tape, this video of the uterus just sitting there doing nothing. And imagine having to sit there and watch it for hours at a time. Watching a uterus do nothing is pretty boring. So one of his colleagues got bored and started to fast forward it. And he noticed when he was fast forwarding through it that the uterus was actually moving. It was just really slow and really subtle. And when they went back and did subsequent experiments and watched these movements, what they noticed was that during times like the menstrual phase and starting into the proliferative phase, the uterus contracted in a downward direction. So it contracted so things would move downward and out of it. And that certainly makes sense during menstrual phase and even in the proliferative phase of it. But the movement in the proliferative phase was much more subtle, but it was still contracting very, very slightly, but in a downward direction. But again, that makes sense because remember, this is open to the outside world. So there's still potential that things could move up in there, but the uterus is constantly trying to get things to move out. However, during ovulation, the muscular contractions reversed and they contracted in an upward direction, which again, now that kind of makes sense because that's going to help the sperm make their way up to the fallopian tube. It's pretty genius. And the exciting thing about this is a new revelation. This is something that was just discovered not that long ago, literally within the past couple of years, with at least, visual proof that this occurs. So I think it's really kind of cool. And nobody else seems to care. Okay. The structure of the vagina, it is a collapsed tube, and they say 3 inches, more like 4 inches in length on average. But it does have the ability to stretch, and it has a lot of those folds called rugae, just like we saw before, like in the stomach or in the urinary bladder. Not surprisingly, there's a mucous membrane because, of course, this is direct contact with the outside world. So we're going to create some sort of mucus. And then that goes up right up to the up and sort of around the cervix a bit. The hymen is this additional mucus fold that can be found around the border of the vaginal introitus. And there's lots of variations to the hymen and how much of it is actually there. There's actually 3 functions of the vagina. They list 4 of them here, but actually the first 2 they list here are kind of one and the same. First function of the vagina is to hold the penis and the ejaculate during sexual intercourse. So that all falls into the category of what they have here as the first 2 functions. It also, of course, functions as a pathway for that menstrual flow, the blood and the tissue and everything to be removed out of the body. And then finally, it acts as part of the birth canal for the baby to come through. Makes sense. Going toward the outside again, the vulva. I talked about the mons pubis, the fatty pad that covers the pubic bones and the pubic symphysis. Add some cushioning. There's pubic hair that is there that does offer extra lubrication. Now, this lubrication is not for internal lubrication. This is for skin-on-skin lubrication, which is why that is there. It's also, of course, there like any other body hair to help move particles away from the body. I talked about the labia minora and the labia majora. The majora are the larger, thicker lip-shaped structures that have a pubic hair, the labia minora, or the thinner inner lip-shaped structures that do not. The clitoris is an interesting organ of stimulation, sexual stimulation. And most, when I discuss the clitoris as being sort of this mound of erectile tissue, but that's just the glans clitoris. It actually extends, oops, more like what's called a signet ring design, which kind of makes more sense. So this is part that is exposed, but it kind of makes sense that there would be this additional area as well. Quick overview of the organ of sexual response in the female. We talked about the external urinary meatus or urethral meatus. They call it the vaginal orifice. I call it the vaginal introitus. It's the opening to the vagina. And then there are some glands, often referred to as the BUS glands, the Bartholin, urethral, and Skene's glands. But here they've only listed the Bartholin's glands, which are sort of in the area just around the vaginal introitus. And they add lubrication. And these are ones that can actually have cysts that can sometimes form in them. Okay. Menses, that is what people, that's what a woman would call her period, her menses. The very first one is called menarche, meaning her very first period ever. The average age right now in the United States is 10. It used to be 12, but it's actually gone down a bit for reasons that are unclear. And then menopause is the time where she produces less and less estrogen to eventually creating not enough to actually cycle and release eggs anymore. So this is something that happens around 50. The average age of menopause is around 50. However, it is not something that happens overnight. It is not something that begins on a Friday and ends on a Monday. This could take months and years before a woman to go through this process. And menstruation, okay, we talked about that. Every month she is going to release an egg from one ovary, and it's going to go back and forth. So for 1 month it'll be right side, left, next month it'll be left side, next month it'll be right side, next month it'll be left side. What happens if she accidentally releases 2 eggs and they both get fertilized?
Twins.
Twins. What do we call those twins?
Identical.
No, these aren't the identical one. These are fraternal twins, non-identical or dizygotic. These are from 2 different eggs. So actually one can get fertilized with a sperm that has a Y chromosome. One can get fertilized with a sperm that has an X chromosome. So one could be a boy and one could be a girl.
Oh, a boy and girl, yeah.
Yeah, so they're still twins, but they're not identical. The identical twin happens when one egg gets fertilized, and in the process of changing and becoming a blastocyst, somewhere along the way, for whatever reason, that cell spontaneously divides and creates, so the cells create 2 new groups of cells. And that, let me show you, that is when identical twins occur. So 1 egg with 23 chromosomes, 1 sperm with 23 chromosomes, they meet, and then a brand new cell that has never been seen before in the universe with 46 chromosomes is created. And then almost immediately, that cell is going to make a copy of itself. And then those are going to make copies. And then and so on and so on, eventually becoming a person. But for reasons still unknown, if this spontaneously divides, then each of these will eventually go on to become two individuals. But they all come from, both of these guys here come from this original cell with that original information. Why this happens, why it spontaneously splits, nobody really knows. If it only partially splits, so if there's this like developing blastocyst that doesn't split completely, then what ends up happening
Is that when one twin dies?
conjoined twins.
Oh.
One body, two heads. One head, two bodies. Sometimes one body, four legs. Just sort of depends on where and how much of this split occurs. This is why all conjoined twins are identical twins, because they all started way back here. And this is still considered a conjoined twin, even though all you see are extra legs. It's actually because that just happens to be where the split occurred and didn't occur past that. And people often ask, well, how much more is in here? How much pelvis, how much intestines? Yeah, no idea. You don't know that until you start taking x-rays and MRIs and investigating that way. You don't know how much more of the person is there until that happens. Just like if you have to separate two twins that are joined like at the head, something that Ben Carson had done in his youth, you have to know how much blood supply they're sharing right here, because that could be very dangerous. So here's an egg. Here's a sperm.
I'm
That's a gamete.
sorry to interrupt you. Do they
That's
know when the
that's a
woman is pregnant that is the case, like that she's having conjoined twins?
Oftentimes, yes. It depends on how far along in the pregnancy, but yes. So a gamete, a sperm with another gamete, an egg, they come together and they create what's called a zygote. That's a Y, zygote. So identical twins are monozygotic. Mono means one egg, or one zygote from the one fertilized egg, and dizygotic are fraternal twins. So these are identical. These are fraternal. Come from the same place. Okay. Throw that. Get back to where we were. It's 31. All right. Talked about. Now, see, they're only showing in this. They're only showing the menstrual phase. And they have day 1 through 5. And again, I said approximately day 1 through 6. The proliferative phase, which is approximately day 7 through 13. Ovulation, which occurs on approximately day 14. Now, technically, if you look in the medical books, they will tell you this occurs on approximately day 10 plus or minus 4 to 6 days, or 10 days after the first day of our last menstrual period, plus or minus 4 to 6 days. So it's an approximation. So we just say day 14 because that's pretty close. The secretory phase is what occurs from day 15 to day 26. And then the very, 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 I can't stress this enough, ischemic phase is what occurs on days 27 and 28. So that should be included here, and I don't know why it's not. Because in order for menses, the menstrual phase, the menstrual period to occur, there has to be the ischemic phase. And that's days 27 and 28. So technically they're missing part of it here. It's an important part, very important part. That's a rupturing follicle showing an egg. Now, one of the things that they talk about here that I don't really agree with again is because they talk about these hormones that regulate that cycle, follicle stimulating hormone and luteinizing hormone. But the real hormones that make this happen are estrogen and progesterone. And as I said before, way back in the endocrine system, hormones work in a chain reaction fashion. That one hormone causes the release of another, that causes the release of another, causes something to happen. So the follicle stimulating hormone regulates the estrogen, the luteinizing hormone regulates the progesterone, and that causes those changes to occur. So the real changes are with estrogen and progesterone. This begins to show some of that here. And I say that importantly because it is the change that occurs with the release of estrogen from the placenta that actually maintains that frozen cycle so that it keeps it from moving into the ischemic phase. Kind of a big deal. Okay, we talked a little bit about that already. So, when a couple cannot become pregnant, we already know one cause might be the result of a low sperm count. But if a couple cannot become pregnant, what we say to them is that they must try for a year, meaning knowing when she's ovulating and making sure they take the necessary steps to try to engage during those important times. If after a year goes by and they still haven't gotten pregnant, then we start testing. We always test the man first because it's easy, it's cheap. All you have to do is get a specimen and do a sperm count, look for things like how many sperm there are, how they moving around, or is there any deformities? And that's it. And you can come up with an answer very quickly if that's the case. However, most of the time, that is not the case. Most of the time, the reason is somewhere in the female's body. There's something that is not allowing it to occur in her body. And that's because there's a lot of complicated mechanisms that are keeping that cycle occurring and that have to be in place in order for implantation and growth to occur. Men are simple. The machinery is simple. So there's not going to be a lot of mistakes. But the more parts you put into a piece of machinery, the more likely the machinery is to fail or to break down. So by putting more parts into this female anatomy and physiology, there's more likely an area where it won't happen, where pregnancy won't occur. So most of the time, it's on the female end. We test the male first because it's cheap, it's easy, and we can rule it out quickly. But there's lots and lots and lots of reasons why there might be a problem on the female end. Everything from anything that can cause dysfunctional uterine bleeding, anything from the position of the uterus to the vaginal environment to cirrhosis, causing change in the menstrual cycle. So lots and lots of things that can occur. We talked about that. The breasts are included as part of the female reproductive system because they obviously are going to add to the nutrition portion after the child is born. And there's also changes that take place as a result of the different hormones. So of course, we're going to have to include them in this. They are located on the chest, not surprisingly, on top of the pectoralis muscles, and they are made up mainly of fat and lactiferous lobules and lactiferous tubules that produce the milk. So most of what you see is that fatty tissue. These suspensory ligaments, they're actually not just found down here, they're found throughout the breast too. Oh, you can see them up there too. They just put them in, okay. They just marked them here. These are called Cooper's ligaments, and they add a lot of density and a lot of strength, upward pull on the tissue. So this is why younger women are going to have breasts that are more dense and firm, and as women get older, those suspensory ligaments lose their integrity, and so the tissue is a little more lax. You can see the lactiferous lobules there that are going to be producing the milk. The nipple, of course, is where we're going to find these pores that are going to allow for the milk to leave those ductules. The areola is the hyperpigmented area that surrounds the nipple, and that includes some sebaceous glands, which is going to help, I don't say eliminate, decrease the amount of the damage that can occur as a result of like babies breastfeeding. Very simple structures, really. And you can see in here inside of one of those lactiferous lobules with the milk producing cells that are going to fill up this space and then move into the lactiferous tubule, which is going to cause the release of the milk. Back in the endocrine system, we talked about how prolactin is going to cause breast development during puberty, and it's going to cause milk production during pregnancy and afterwards. And that oxytocin is the hormone that causes the release of the milk, the ejection of the milk, when the baby starts to suck or even starts to cry. Okay, I talked about that. Lactation, secretion of milk for the newborns. Talked about some of that already. Okay, so why is breastfeeding a good thing? Well, human milk has a lot of good stuff coming in it, a lot of good fats and nutrients, as well as antibodies. That first milk that is released, sort of that yellowish, thickish fluid, that is called colostrum. And colostrum is where we're going to find a lot of those immunoglobulins, especially immunoglobulin A. You know, most immunoglobulins are found in the blood. Immunoglobulin A is found in a lot of breast milk and tears, saliva, things like that. So it's a good way for the baby to get some of these antibodies as well. And then there's definitely a bonding that occurs with mom and baby, or increases the likelihood of bonding to occur between mom and baby. Now, what happens if mom just can't breastfeed for whatever reason? No big deal. We get the baby nutrients other ways. So we never want mom to feel like she's a bad person if she doesn't breastfeed, because sometimes moms just can't. growth and development. Prenatal period starts at conception, postnatal period. Well, that's everything after the baby is born. Okay, we talked about meiosis. That is when those new sperm cells, for instance, are made with the egg cells, and they only have half the number of chromosomes. And we talk about all the shuffling of the chromosome material, the DNA at that point. Talked about fertilization and conception being the same thing. When one sperm cell releases its nuclear material into the egg immediately creates a brand new exterior so that no other sperm can introduce their genetic material, because that would be too many chromosomes, and that would cause, well, problems. Too many chromosomes is bad. So as soon as one sperm is able to penetrate and release its nuclear components, all of its chromosomes, and then automatically the egg changes. The whole outside of it says, nope, nobody else come in. Here we can see a nice follicle releasing the egg. That's the ovulation part. Remember, the fimbriae, those little projections, are going to do two things. They're going to brush up against the follicle and help to cause it to rupture. And they're also going to help direct the egg into the infundibulum, the first part of the fallopian tube. Notice where it gets fertilized, where the sperm meets that egg is way up, somewhere between the ampulla and the infundibulum, typically. And when that happens, a brand new cell is created. And then that brand new cell, that zygote, is going to become 2 cells and then continues on 2 to 4, et cetera, all the way down to this blastocyst level. And you can see how the blastocyst has that projection of it, which is going to cause implantation. Now, if implantation occurs somewhere in here, we would call that an ectopic pregnancy. Specifically, they would say that's a tubal pregnancy, but an ectopic pregnancy can occur anywhere. Because again, ectopic means it's happening outside where it's supposed to. The most common place for it to occur, however, is in the tubes. Once that happens, that's bad news, because it's really difficult to take that and move it from the fallopian tube into the uterus. Once it starts to implant in the fallopian tube, that's about it. And I don't say it's impossible, because in just the past couple of years, they've managed to do it a couple of times, but it's not likely. So that's bad. And if it happened once, it'll probably happen again. So if she has had an ectopic pregnancy, especially in the tube at one point in time, it'll probably happen again, because whatever stopped it and caused it to implant there will probably cause the next one to stop and implant.
Sir, I was trying to, I was going to tell you earlier, but that happened to me, an ectopic pregnancy.
Yeah.
And that happened before I had my 2 daughters. So luckily it didn't happen again, thank God.
Yeah. But
I did have to get surgery and get it taken out, and the pregnancy was unsuccessful.
Yeah. Yeah, it's one of these things that happens. And if there's any sort of scar tissue, that can cause it to happen, or just any place that just happens to find a little bit of a blood supply or any sort of blockage in the pathway. Which is why if a woman has had like a tubal ligation, like if she's had her tubes tied, what you'd hear it as what we call like a tubal ligation, that actually increases the risk of a tubal pregnancy, because there might be a small opening where the sperm can get through and meet the egg, but the egg is too big and can't go and continue through to the uterus. So by getting a tubal ligation, it actually increases the risk of ectopic pregnancy. Not more so than a person who's already had an ectopic pregnancy. But remember, 1 month the egg is released from one ovary, the next month it's released from the other one. So if there's a blockage or a problem in one fallopian tube, the other fallopian tube might be just fine. Oh, wait, does it say it here? Okay, good. Yeah, it does include ciliary movement of cilia, help to move the sperm. Well, actually, no, it's going the other direction. It's helping move the egg, not the sperm. Except during that, well, no, not even during ovulation, because the egg's got to move down. All right, we talked about that. We talked about 22 chromosomes, talked about the zygote. Mentioned some of that. It does mention that chorion here develops to become part of what will become the placenta. And this is amazing how quickly this happens, where a brand new cell is created here, and then almost immediately that cell makes a copy of itself. And now you have two cells, and then shortly thereafter, those two become four, et cetera, et cetera. It's amazing how fast that happens. The placenta acts as sort of a filter where it is going to take blood from the baby and allow the small blood vessels to pick up nutrients and get rid of waste products. And of course, remember that mom's blood and baby's blood do not mix, at least not until the actual delivery. Then there's only mixing of blood because the placenta is tearing away. But mom's blood and baby's blood do not mix. And if you see, here we go. If you look at the placenta, to put it down flat, it's about the size of a dinner plate. And it could be about a 1/4 inch to about a 1/2 inch thick on average across the whole part of it. And you can see the umbilical cord here as well. The umbilical cord has 2 arteries and then 1 vein, 2 umbilical arteries and 1 umbilical vein. You can see the position of it with regard to the baby in the uterus. If this is the cervix down here. Oh man. Okay, this is demonstrating, notice the big spike in HCG, human chorionic gonadotropin hormone, and then it goes way down. Little surge at the end, but if she tests down around here, oops, if she happens to pee on a stick down around here, it might not be enough to actually show up on the stick. So it might actually show up that she's not pregnant, and obviously she is. Gestational period, it's about 40 weeks. They say approximately 39 weeks. It's about 40 weeks. But on normal pregnancy, we'd always say goes from 38 to 42 weeks. That's the spread. And in fact, the newest ACOG, the American College of Obstetricians and Gynecologists, numbers are actually 37 weeks to 42 weeks. Still falls under what we call a normal pregnancy. So that's a 4 to 5 week window. So when that approximate date of delivery, the EDD, estimated delivery date, occurs, and the baby doesn't come on that date, or the next day after, or the day after that, and she says, well, my baby's 3 days late, it's not really a big deal. Because remember, the estimated delivery date is just a guess. It's a guess based on average, how long it takes for a baby to go from being conceived to being delivered. And dates that we guess is approximately when the baby was conceived, because we don't know for sure unless we do in vitro fertilization. There's no real way of knowing exactly when conception occurred. So it's just a guess. So there's a 4 to 5 week window around that time. So for her to say, oh, baby's 3 days late, okay, well, not really that big a deal. And as a reminder, The baby has nothing to do with the delivery. The baby doesn't determine when it's delivered. That's mom's uterus that decides to start pushing it out. The baby has nothing to do with being delivered. So if you're going to blame somebody for being late, blame mom's uterus. Embryo. Goes up to 8. We call it an embryo for the first 8 weeks. We call it a fetus after that. And after it's born, you can call it whatever you want. Quite a bit of growing happens. Okay. Now, stages of labor. Now, they list 3 stages of labor. There's actually 4 stages. And then with stage 1, we actually break stage 1 down into 2 phases. So in stage 1 of labor, and true labor means that there are regular contractions and that there's cervical dilation. Both of those things have to be present in order for us to call it true labor. So stage 1 of true labor is when the cervix goes from being dilated from 0 to 10 centimeters and effaced from 0 to 100%, which means the thickness of the walls. So the first phase of the first stage, we will see the dilation go from 0 to 4 centimeters and the effacement go from 0 to 50%. And then the second phase is the rest of that. The reason why we use that as sort of a guide is because if we're going to use something like Pitocin, we wait until after she's into the second phase of the first stage, where we are actually going to give that Pitocin when she's at least like 5 centimeters dilated or more. We'll also see the rupture of membranes happen here, or the bag of water breaks. Stage, and that's can last for a while. Stage 1 can last for quite a while, several hours. Stage 2 is when the baby's head is going to be crowning and then ends with the baby being delivered. So delivery of the baby actually happens in the second stage of labor, and that is what ends the second stage of labor. Then anywhere from a few minutes up to 20 minutes after that is the expulsion of the placenta. And I say up to 20 minutes because if it takes more than 20 minutes, then we got to go looking for it. So typically happens within the first 20 minutes. The fourth stage of labor, we used to only use if there was a complication, like postpartum hemorrhage. However, again, the newest guidelines by the American College of Obstetricians and Gynecologists, and this is not newest, I mean, this has been 5 or 6 years now. All the books are including this. As the fourth stage of labor is what's called maternal stabilization for the next 24 to 48 hours. Basically just saying, let's make sure mom is good. Let's make sure she's stable for the next day or so. So that is the fourth stage. Now we're going to see the baby sort of, you can't really see in these pictures, but we're going to see the baby take on these different positions, starting out with what we call engagement. Or you might hear people say, oh, the baby has dropped, meaning it's moved into the lowest part of the birth canal. Okay, we'll go with that. Technically, we call it engagement. That is followed by what we call descent, then flexion, internal rotation, extension, external rotation, and expulsion. And you could imagine the baby going through these different posturing. However, the baby's not making any of these movements. It's mom's uterus that is squeezing, causing the baby to make these movements. And as the baby comes out, you'll notice it comes out, we call occiput anterior, facing down, with the vertex, the cephalic presentation, the top of the head, the vertex coming out first. That's kind of what we expect to see. And then as soon as that head comes out, you will see that external rotation. The baby will turn its head, will be, again, it's not the baby turning its head, it's the uterus turning the baby. So the baby's head starts to rotate. It will be clockwise. So it'll be like to the baby's right. And you'll see the baby's right shoulder also turning to the right. And then the first shoulder will come out and the second shoulder. And then once the two shoulders are out, the rest of the baby is going to come right out after that pretty easily. And then we're going to clean out the baby's mouth, make sure there's nothing in there like meconium, and give the baby a quick wipe off, and then cut the cord. Then wait for the placenta to happen. Oh, we're going to hand the baby off too, by the way, because that's no longer a problem. All right, we talked about identical and fraternal twins. Oh, here's a good representation of that happening. How one becomes two versus two that just are always two and have always been two. I think that was it. That's a baby growing up to be a person. This is something I talked about yesterday. I want to include as well. When that baby is born, we are going to check things like heart rate, respiratory rate, response to stimulus, muscle tone, and skin color. We're going to check these 5 different things, and we are going to assess them and give them a score ranging from 0 to 2, which means if there's 5 things with a score ranging from 0 to 2, the best possible score would be a 10. And we're going to check these things at 1 minute after birth, and then again 5 minutes after birth. And what we want to see is we want to see an increase. So if the child had a score of a 6 on those, when we assess those areas at 1 minute, and then a 9 at 5 minutes, well, that's good. As compared to if the child had a 6 at 1 minute and then a 7, or if the child had a 7 at 1 minute and then a 7 again at 5 minutes. We want to see that increase in those things: heart rate, respiratory rate, response to stimuli, muscle tone, and skin color. APGAR score was named after the anesthesiologist. I'm sorry, I do not remember her first name, but I know she was an anesthesiologist who came up with this. So some people think APGAR is like an abbreviation of the 5 things that we check for, but it's not. That's just her name. Speaking of which, if you've ever heard of a pap smear, PAP, P-A-P, does not stand for anything. People think that's an abbreviation for pelvic exam of some sort. Nope. Pap smear was developed by a Greek physician named George Papanikolaou, and so they named it after him. But of course, nobody wants to call it a Papanikolaou smear because nobody's going to write all that down, and certainly don't know how to spell it. And they couldn't call it a George smear. That would just sound weird. But that's where that comes from. The physician who created that assessment test for collecting cervical cells, his name was George Papanikolaou. And that's all I have for you. This was the last anatomy and physiology lecture of the course. I hope you learned some things. I hope you enjoyed the course. Most importantly, I hope you learned some things. Yeah, that's most important. Hope you learned some things. But I have to end the course, so goodbye.
Thank you so